Hello, everybody. My name is Nicole Goldfarb, and I'm a speech language pathologist and certified oral facial myologist. And we are here with Airway Answers, expanding your breadth of knowledge. And this visual podcast is through Airway Circle Radio. So we thank everyone for joining us today. And I have the pleasure of introducing and interviewing Dr. Ilya Lipkin. Probably most of you have heard of him before, the MSc expert. And let me do a little bio introduction. Dr. Ilya Lipkin is an orthodontic specialist and dental facial orthopedist with over 20 years of clinical experience in private practice. He earned his dental degree at NYU College of Dentistry and completed his dental residency in orthodontics in the postgraduate orthodontic department in 2001. And he has a practice in Emerson, New Jersey, correct?
Actually, Westwood.
Okay, West, and that's New Jersey?
It used to be Emerson.
Okay, it used to be Emerson. Okay, in New Jersey. And Dr. Lipkin lectures nationally and internationally on multiple orthodontic topics, including but not limited to skeletal expansion, which will be a big topic we talk about today, airway, TMJ, and various orthodontic techniques and technologies. So before I start the talking to Dr. Lipkin, Dr. Ting, who is my orthodontist that did my MSc a couple of years ago, wanted me to make sure when I introduce Dr. Lipkin to say that Dr. Lipkin is the best orthodontist Dr. Ting has ever known. So that speaks volumes. So it's great. I feel you both are like MSc skeletal expansion experts. So I feel like a big thing right now is MSc, MARPE, skeletal expansion. It's just a very popular, amazing technique right now. And a lot of people have questions. In fact, when I was checking Facebook today, in some group, some craniofacial group, someone posed a question that was solely about Dr. Lipkin and your technique. So I might be able to ask that here, which was kind of fun that I saw that today. So let's get started. I'm curious how you became interested in MSc and sort of a shift from maybe more traditional orthodontic techniques to airway focused.
I mean, we always did expansions from the day one in the practice. Eventually just when I graduated and the person I bought the practice from, even in some of the cases where we treated patients with extractions, we still did expansion. Essentially, but there's a limitation of how far how old the child should be to get expansion that's going to be stable and it's going to stay long term. So when the TADs came out, the mini implants, I learned those back in 2007. And then in 2010, I saw an article by Dr. Van Moon, actually a couple of articles about the MSc and TAD-supported expanders. So that's, and then I tried my first one in 2012. So that was basically just for gaining space, making room for teeth, improving, getting a wider aesthetic outcome, and airway certainly was not a big part of it, but some patients started to reporting signs and symptoms of improvement, and light bulb went off.
Okay, so that's actually interesting because it was first the skeletal expansion was more like sort of an aesthetic or cosmetic, getting this space.
It just allowed me to do expansion on the kids or young adults that were not growing. Initially it would be like a middle to late teens, like okay. In my early 20 from between 2012 and 2015, and in 2015, inspired by Dr. Ting, I tried the MSc on the adult, and that worked. So it just became a major tool in my toolbox.
And then patients started reporting better breathing or other airway.
A lot of patients started saying, "Oh, I stopped snoring. I feel better. I feel I can breathe through my nose so much better." And in some of the younger patients, which we tried that, let's say they had really significant underbites, and those very unpredictable with the conventional expanders. And so I tried those on younger kids. TAD support expanders, and that worked really well. So I was very much inspired. And then when your parent tells you, "Oh, my child was 3 percentile growth, and now they're 50th percentile, and they stop snoring," and this again, it's just adds on.
Yeah. And what is the youngest age you would do a TAD supported expander?
It's an excellent question. Renata Nemi asked me that yesterday. And
We're always on the same page. Uh-huh.
yes, yes, I've done multiple 7, 8-year adults. The youngest I've done was 5. It
Oh,
was
wow.
someone who has a extreme. I mean, this is an extreme case. It was a very severe case. So both underbites and width. It was I felt that conventional expansion would just not do what you should get. So, mom, who was a MARPE patient herself, and orthodontic surgery patient herself, she said, "I don't want my daughter to have what I've had." So she actually the one who suggested if we should do a MARPE on her daughter, and then we did, and the results been amazing.
And wow. And so do you feel the results may not have been as good doing traditional tooth-borne expansion?
Probably not.
And
And not only that, it's just the tooth-borne expanders have limitations. At some point, the maxilla stops expanding and the teeth start to move.
mhm.
So if you do, it's been reported in literature that when you do a conventional expansion, even on younger kids, you lose about half long
Mm,
term. So,
okay.
if this girl, for example, the width of her palate was 24 millimeters and a normal 36 to 40, then, if we would have done 10 millimeters and got her to 35, and she would lose, 5, and then, it would not be adequate.
Okay. So basically when you go back to like upright the teeth after they've been tipped, then you're losing that expansion when you
Not
do.
only that, it's just because the conventional expander, it's pressure through the teeth onto the bone.
Mhm.
So at some point, the pressure from everything else on the bone stops allowing the bones to move, and then you get tooth movement. Or
Mhm.
even after you stop turning, the pressure is still there, but it's not. Teeth are not set in bones. Teeth will move.
Yeah.
So the bones move back, but the teeth stay out.
Yeah. And so for the 5-year-old, how many TADs did that 5-year-old have?
2.
Okay. And then what age do you start using 4 or more TADs?
It would be based on depends on how thick the bone is.
Okay.
Depends on if we're planning to use MARPE for something else,
Okay.
like anchorage and so on. So that's just up until maybe the age of 10, 11. I could use just 2.
Okay. And MSC would just be 4 TADs, right? But then MARPE is more customized where then you could go 6, 8, like that.
I used to customize before we had orthodontic lab like partners. I used to customize my own MSCs. I have a laser welder, so I would just add TADs, and I've done my own 6, 8 TADs based off regular conventional MSC.
Okay. And what is the oldest age that you've done the TAD expansion where you've had success?
63.
Okay. That's amazing. And so for the adults, do you have to use a piezo or some other technique to help the suture split?
Yes, it will make it more predictable.
Hmm.
Exactly.
What age do you typically have to start using piezo?
Piezo.
Yeah.
Usually for males, I would start at the age of 25, and for females over 30. And some people will probably debate me on this, and chances are they, even especially in women, the maxilla will split even without piezo. But I was talking to Mariana Evans the other day, and then she said, I don't do piezo as often, and most of my patients split except one. And I said, well, the reason I do Piezo because I don't want to have that one.
That one. Hey, this is great. So this is interesting. I did see someone who just had an adult male had a MARPE installed with Dr. Evans just I think yesterday, and I asked the question, "Did you use Piezo?" I wasn't sure. It didn't look like it, so it sounds like she's not even needing it as often as maybe we once
Yeah,
thought.
I mean the procedure is so non-invasive, and so I dare to say simple.
Okay.
That it takes maybe 5-10 extra minutes of a total chair time. So if that helps me to eliminate that one that one uncertainty, I will use it.
So let's can you explain the piezo and what that is for listeners that might not know?
It's basically an ultrasonic knife. And we use before we used piezo for skeletal expansion, we used to do something that's called chordae punctures, meaning we used to do just perforations right along the midline, which was extremely tedious, extremely slow, and also extremely unpredictable.
This
So
podcast is brought to you by the members of Airway Circle, the premier community for healthcare professionals passionate about airway health. If you're a medical professional looking to enhance your knowledge and stay ahead in the rapidly evolving field of airway health, we've got something special for you. By joining the Airway Circle membership, you're not only helping us bring this podcast and our professional directory to the public at no charge, you'll also gain exclusive access to a treasure trove of knowledge with hundreds of expert lectures. Whether you're a seasoned practitioner or just starting your journey, our diverse range of topics covers everything from breathing, craniofacial development, myofunctional therapy, palatal expansion, to oral ties, sleep, and gut health. We would like to extend our gratitude to a few of our loyal listeners who share Airway Circle with their colleagues. To claim a free month of Airway Circle membership, visit www.airwaycircle.com and use the code AIRWAYANSWERS. But don't delay, because this offer is limited to 5 lucky individuals every month. And that's not all. As a member, you become part of a vibrant community of like-minded professionals, have the opportunity to learn from experts, participate in live Q&A sessions, and engage in discussions that will deepen your understanding of airway health. So don't miss out. Join Airway Circle membership today and come grow with us. Airway Circle, where knowledge meets community.
piezo, it's basically same perforations, just more efficient.
Okay. And it's just
much quicker.
like a straight line, a straight cut. Is there a lot of bleeding?
There's no bleeding at all. We used to do it much more aggressively in early cases. I think, and I've seen sometimes patients, some of the colleagues keep posting the cases. Sometimes they still go too aggressively, but it's doesn't need to be that aggressive. So it's not, no, there's no bleeding. It's really pretty uncomplicated.
And what do you mean aggressive? Like, how would you be more or less?
Oh, they would used to do just like they will just split the entire maxilla literally with the Piezo knife.
And you don't have to go all the way back in your technique, or?
No, you just don't have to make it that continuous, that deep, that long. It requires much, especially with the custom MARPEs, requires much less invasiveness.
Okay, like a shorter depth. And then do you do that the piezo before installing the appliance?
Yeah.
Okay.
Right before.
Okay. So I had my MSc, I think it was 2 years ago, maybe a little bit less, and I was pre-piezo. So I got to have the joy of 18 quarter punctures. I think actually Dr. Tinker, he did 17, and I was like, just do one more so we end on an even number. Just my little superstition. But that was uncomfortable. And he said now it's not as painful with the piezo as it was with quarter puncture.
That's true. Very true.
Great. Well, that's great for me that I got to do that. But either way, it wasn't even that bad at all. It wasn't. And you're numb. And then later, over the counter medication like Tylenol worked.
Yeah, most patients, with an extremely rare exception, say that they would always expect it to be worse than it actually was.
Do you prescribe a painkiller after, or just over the counter medication?
Just over the counter. I have never. Nobody ever. I mean, there was one patient who she was. I mean, I would say maybe she just was more sensitive than other patients. So she, on a second day post piezo, she said that she was in significant pain. So I prescribed her something strong, which like a Vicodin, which she never actually picked up because by the time she got there, pain went away.
That went away. Okay, yeah. It almost seems like for things like that, if you beat the pain before it gets to you, like take that Tylenol or Advil before, usually have it under control. And it's funny because I talk a lot about the skeletal expansion because to me, this makes the most sense, like as a maybe avoiding jaw surgery option for a lot of adults. So when I did my MSc, I did it with my son who was 8. So we both did that together. So I get so many people contacting me, parents wanting to do it with their child. So yesterday, a mother is going to get the Piezo with her 15-year-old daughter. So it's like a family affair. So people are asking all these questions like how much time do I have to take off work? How much pain is there? Do you typically tell your patients they have to take off work for a few days or curiosity?
Not typically, but if I mean most patients would they always ask about the pain factor, and it's usually the first day. The day off placement and the day after. It's always best to take off a day if if they feel they're uncomfortable or just in case. I've had some patients went back to work the next day, so it kind of varies.
Okay. And then when you install it, then do you start turning for the patient at the installation and then have them turn daily, or is it possible
I
to
I
set up protocol?
I actually I used to turn right away. I no longer do that. So we usually start turning about 4 or 5 days after the
Okay.
installation.
Okay. So what are some of the changes in this type of skeletal bone expansion that have occurred over the years? It sounds like we went from punctures to piezo, maybe adding more TADs. What are other changes that you've experienced in
Well,
technique?
you start analyzing your own failures, right? So I started using MSCs, and initially I was very successful, probably because I didn't follow the protocols that were written in the book.
That's a good
um,
lesson.
uh, yeah. So essentially, what the way I was placing it, where it made sense, and it turns out if I were to do it by the original protocol, I would have done it. I would not have had a success. So then you start reading about it a little bit more, and then seeing placements, and then you start trying it that way or various different ways, and then when it fails, you start analyzing. So in some of my failures, I started adding more tabs or putting them in different spots or adding little eyelets to increase the number of tabs. I even tried uh, a double MSCs before the custom ones were available. I still use conventional MSCs on younger kids. For adults, that's only custom.
Okay.
And then the customization, because it allows you to see where you're placing the tabs, and it allows you to see where the bone is. It's the precision's gotten over just literally just last 3 years, when it became absolutely incredible.
That's what it
So yeah, so it's now with the customs, it not only allows you to do the expansion, but you can add certain parts to it. Let's say for intrusion, for retraction, to treat gummy smiles, severe protrusion, and so on.
okay.
So it
Um,
became much more versatile.
okay, so yeah, it's just way more customized, it sounds like. And when
Yeah,
you maybe add more TADs for certain patients, what's the most amount of TADs you've done?
usually 8. I mean,
8?
that's my on adults over at least 30. That's my go-to.
Wow.
6 to 8.
Okay. Okay. And then if you do the piezo on all of them, are you getting 100% success rate since you've been doing that technique?
Last 2 years, I've had 100% success.
Woo! Okay, that's a big deal. So last 2 years, you have never had a patient and success being suture split, right? That's how we
Yep,
would define success.
yep,
That's
exactly.
amazing. That's
Including Dr. Ting himself.
There you go. I remember when I went to see him, I think he had just seen you. So suture split and all up to age 63. And older ages, have you not tried or it's less successful beyond the age of 63 or
No, just did not have a patient who got older who would agree to do the MARPE. If
interesting?
if if, if tomorrow, like yesterday, I had a 72-year-old,
Okay.
he's thinking about it. If he's going to go for it, I'll do it.
So okay,
I don't think.
I was
I
gonna
don't
say,
think age.
what's the oldest?
I wouldn't use age as a limit.
Okay, so there wouldn't be an age where you'd say no, like a 75-year-old, you would, if they're willing, the bone seems
I
fine.
mean, you have to consider the risks. Obviously, for 72 is the healing, the age, what the implications of possible other things like healing and infection. So that those are considerations. For example, if tomorrow the 82-year-old will come and they have diabetes and this and that, and probably, even though it might be the case, I might not do it just for those reasons.
Right. And osteoarthritis, things like that, you would have
Oh
that.
yeah, there's multiple little things that needs
Okay.
to be considered.
So do you think when you're doing transverse expansion with these bone-borne expanders, are you getting any AP growth?
Well, you could affect the AP change absolutely, whether it's using a face mask or there are other contraptions that you could do.
So you
But
need to add on something. You wouldn't naturally get any forward growth with just
right, I mean, with the pure expansion only, no face mask, nothing, you're still going to get a teeny bit AP change. That's just because that's how maxilla expands.
Okay, can you explain that a little more? So that's interesting. So doing the transverse, you will get a bit of forward growth.
I mean, it's microscopic, maybe a
Okay.
millimeter or so, but yeah, there is a little bit of a forward change.
Okay. And in children, that's true for even RPE, right? When you do any is that more
Yes.
prominent in a child than an adult that you're going to get forward growth from transverse expander?
Not forward growth, just forward change from the expansion.
Forward change. What do you mean forward change?
Forward displacement. Growth implies, it's a growing.
Okay.
That's not growth, it's just displacement.
Okay, this is really interesting. Forward displacement. So what's going forward?
The maxilla get, from the research that even before the MARPEs,
Yeah.
in a conventional expander, the upper jaw, the maxilla gets displaced slightly forward by about maybe half a millimeter. I forget exact numbers.
Okay,
but you do get some AP change from just doing expansion alone.
Yeah, because I remember hearing a little bit of research on that. I think Dr. Kevin Boyd talks about that as well in children, which could potentially maybe cause some of that tonsil nanoid reduction as well, that decrease in airflow resistance. Growth.
Could be.
Interesting. So when I had my MSc, I felt that I got some forward growth. And for me, it felt like my tongue was no longer crammed back because perhaps it could come wider and then come forward versus just cramming back. So I felt like I could breathe better. Even like tipping my chin down, I could get airflow where I couldn't get any air through my nose with my chin down without going into a class 3. So I felt this a little bit of forward change, perhaps as a byproduct of having more space for the tongue. Interesting.
Sure.
So do you think these TAD-borne expanders can eliminate the need for jaw surgery in patients? And I mean like a double jaw surgery potential patient due to sleep apnea or airway issues.
I mean, in some instances, it can. I don't think, the surgery would always be a gold standard for sleep apnea patients. So, and the sleep in general, the airway has so many different levels. So for some patients, just expansion and a face mask would work, and I've seen that happen. And for some patients, that might not be adequate. It all depends on the jaw structure, because someone who's got a recessed lower jaw and their posterior airway is narrow, you could expand, into infinity, and that will never improve.
Is this type of mid-palatal sutural expansion a good precursor if someone needs jaw surgery?
Oh, yeah, because a lot of patients have, if they do have a transverse discrepancy, then certainly MARPE in comparison to doing a surgically assisted expansion, it's way better. Because yeah, with the surgery, before we had MARPEs, we used to for cases that had transverse discrepancy, we either used surgically assisted expansion, where literally the surgeon just splits the maxilla in a couple of pieces, and we use a conventional expander to split it. The procedure is extremely painful and extremely, extremely invasive. It's basically same orthodontic surgery because they do the cuts in the middle and under the zygomatic bones. And I usually, again, in my experience personally, patients that had surgically assisted expansion don't usually get as much of a nasal breathing improvement. Another way to get the transverse discrepancy in the surgical cases is where they split the upper jaw in 3 different pieces, or sometimes even 5 different pieces, and set it in a different spot, like a little mosaic. But that's extremely unstable. Not extremely, but it's unstable and much more likely to relapse. So using MARPE for those surgical cases has improved the outcomes dramatically.
So in those surgical cases, they're not doing like a cut on the midline sutural area as a MARPE. Okay, as a MARPE
Right.
would.
Right, exactly. So it became what sometimes for orthodontic cases they will split the maxilla in 3 to 5 pieces. Let's say 3 generally if they have to fix the transverse discrepancy. So now it became single piece versus 3 pieces. It's a much safer surgery also.
Okay, so maybe in a pre-surgical patient, you would do MARPE, and then after they've got the transverse, then they would go in for the jaw surgery?
Yep, exactly. Yeah. That's how it usually goes.
Okay, that's interesting. And how often do you combine the MARPE with a reverse pull face mask or any other thing to grow that jaw forward?
Whenever there is a call for it. So if there is an AP discrepancy, we use face mask. And I know there is some people use it indiscriminately, and then it's not always warranted or necessary, or sometimes it could create a problem. So I've just seen on some comments and posts, some people say, okay, we did the MARPE and we did the face mask, and look how the upper jaw came forward, and now they have a giant overjet that they have to fix, and they can't fix it.
Okay.
So it has to be a certain type. I wouldn't, it's not how often I use. It's just in cases that call for it, I use it.
So would an adult be able to get forward growth after MARPE plus?
Oh, absolutely. Mm-hmm.
Okay.
Yeah. So I have quite a number of adults with they have mild underbites, even in a couple of severe underbite cases where we were able to bring the upper jaw forward enough to correct the underbite.
Okay. So is it true that by using MARPE, it's now kind of loosening the sutures so the reverse pull face mask will work on an adult versus you can't just stick a reverse pull face mask without? So how does that work technically, like the sutures and being able to get the forward growth after the MARPE with the
so you have when the MARPE loosens up all the sutural connections, actually the entire mid face.
Okay.
It's not just the maxilla. So essentially, and then there is by using a face mask, you create an orthopedic force displacing upper jaw and actually hold mid face forward. And a lot of patients who do that, they get a little bit of an improvement in their cheekbones.
Okay.
Don't forget to
installing the MARPE, it's splitting the midline palatal suture, but all the other sutures are loosening in that process.
Yeah, that is correct.
Okay, that's great. Do you find the reverse pull face mask is painful or really uncomfortable? No. Okay.
Uncomfortable to some degree, not painful.
Okay. The pressure. Is there a particular reverse pull face mask that you prefer for your patients?
Just a regular standard face mask. Sometimes there is also a couple of variations on the market that don't rest on the lower jaw; they rest on the chest. One is bow, one is crane, but whatever gets the upper jaw forward.
Okay. Or there's like the cheekbone, like the Grumman's one goes here.
Yeah, that's a no-no.
Okay, and why? And that will push back, or what?
Because when you use when the upper jaw comes forward, everything comes forward, including the midface, even in the cheekbones. So if you put the pressure on the cheekbones, you're basically limiting of how far you can bring things forward.
What about the traditional reverse pull face mask that puts the pressure on the chin? Is that going to push the lower jaw back?
No, I mean it does, but it's not back enough to, it's just it's still, there's still enough resistance from the jaw joints.
Okay.
It's the developing a TMJ problem certainly could be a potential side effect of that.
Okay. And then what about once you get the expansion on the upper, how do you match the lower jaw with that expansion?
That's an excellent question. Same story. I see sometimes people, put posts. They done expansion and they have no clue how to match the bottom. A lot of times in the upper jaw that's narrow, lower molars will have an inclination towards the tongue. So when you expand the top, you need to upright the lower molars, and that's how you get the width of the lower match the width of the top. Now, in some patients, they're not inclined, so for that, you will need to do something as called as FOT, or other used to be known as orthodontics. It's basically a kerdichotomy with the bone grafting that will allow you to move the teeth a little bit beyond their skeletal envelope.
Okay. So you either upright the teeth if they're like lingually inclined, or if you have, would it be possible to also do the surgically facilitated on the lower to get even more expansion on the upper?
Some do, but I really don't find that necessary. I've never seen it being necessary, and there's also potentially some very unpleasant side effects because when you split the lower jaw this way and you start expanding the mandible, you get rotation and twists at the condyles. Even though some people claim it doesn't, nothing. I don't buy it. I know some people who do the chin splits. In the past, in cases that I did see, there was always some issue with the jaw joints.
Okay, that's interesting. Yeah, because I know some are firm believers in if you're going to do the skeletal expansion on the upper, you have to do a surgical on the lower. Otherwise, you're eliminating total expansion.
The SFOT, the orthodontics kerdichotomies with the bone grafting done on the lower, I've never seen a problem. I've never seen anybody that narrow that could not be done that way, and it's much safer. It's a much safer procedure, much more predictable than splitting a chin.
Okay, can you describe what that is? The corticotomy. What is the word? The what? Wolfodontics. What was it?
Right now, current most accepted term is SFOT, surgically facilitated orthodontic treatment. Before it became SFOT, it was something that was called 𝐃𝐈𝐒𝐂𝐋𝐀. There was two brothers, Wilco, Tom and Bill. Tom is periodontist, Bill is orthodontist, and they pioneered that SFOT procedure back in the 60s, actually 70s. They started doing it a very long time ago, and then at that time they were called wax hacks and whatnot by their peers, but they stuck with it. They did a lot of research, and now it's especially last decade or so, they've been lecturing everywhere, and there's tons of publications and proving that that technique does work. So it used to be orthodontics. The official, also there's another term. The scientific term is PAOO, periodontally accelerated osteogenic orthodontics. So because it's periodontal procedure that accelerates the tooth movement and allows you to push the teeth a little bit beyond their physiological limit.
So what do you lift, like the gums? And so what is that?
So they lift the gums. They do, for lack of a better term, like little cuts around the teeth and between the teeth. And they lay down the bone graft, and then they close the flap back. And essentially you have a gum flap, gingival gum flap on one side, gum flap on the other side, and the tooth is in the middle, and it's a mush. Not the mush that that you could just poke through, but it's in physiological terms, it loses calcium, so it becomes moldable. Okay. So then you move the tooth with that mush to a new position, and then after a couple of months, it recalcifies.
Oh,
So, so that's how that essentially, SFOT 101.
no,
That's how that works.
that makes perfect. That is really understandable because I didn't really know how that process works. So then how do they move on the lower? Are they using what type of expanders on the lower?
Oh yeah, you could use multiple things. You could use just an expander. You could use braces. You could use Invisalign. Anything that will push the teeth sideways, and you could use.
Okay. And so a technique like a surgically facilitated technique is what age would that start to be applicable for?
Um, Anybody who's got all of their permanent teeth,
Okay.
I shall say. I've done it, a long time ago on even 13-year-olds. So that would be my earliest.
And then what about so if the teeth are lingually inclined and you don't do a surgically facilitated treatment, but you want to end the case with Invisalign, like this is something I'm having right now. I never had expansion as a child. I just had a headgear and braces. And so, so now I did the MSc and I'm in Invisalign. So we're just uprighting my teeth because I had
Yeah.
the skeletal crossbite, but not the dental crossbite. My teeth were perfect looking before all this.
Okay.
So now with the uprighting, so the upper teeth are tipped buccally, right? So now we're going to upright them lingually, right? So do you feel you're losing some of the expansion you gain, some of the skeletal expansion when you upright the teeth? Well, you're
No,
not
but you
losing
need
skeletal, but losing total expansion.
true, but you need to account for that when you plan your expansion, right? So let's say you need to expand 10 millimeters, but when you upright your teeth, you're going to lose 5. Then you need to expand more, so to account for that uprighting.
Okay.
It all has to be planned out properly.
Okay. So it's expected. Yes, you're losing some of that total expansion, but you've expanded more to compensate for that.
That
Okay.
is right.
I'm writing notes here, so account for the uprating. Okay, this is great. Let's see. What about the concept change from like straightening teeth to kind of changing structure and function and breathing? Did you have like a change in your career with that, or what are your thoughts?
Um, I was never a mainstream orthodontist, as you called it. So I was always trying to go the site, on a separate, different road. Early in my practice, I started off with, trying to coordinate teeth and joints, and airway was kind of always, to a slight degree, was certainly there. But it just became mainstream more recently. One of my jobs that I held in college and dental school is I'm polysomnography technician. I did sleep
Oh,
tests for a living. So what breathing is and what sleep apnea is was kind of very near and dear.
yeah,
Um, and again, and when you start doing the cases and you hear first anecdotal reports, and then you send patients for sleep tests, and they come back and they report an improvement on the actual sleep tests, not just not self-reported symptoms, but the actual scientific proof that what you've done actually worked. So that's kind of became no brainer.
yeah.
So that's how my story went. It started with treating joy joints and teeth, and airway just became a big part of it. But I can't say, I don't like the term airway orthodontist or airway dentist. That implies you don't treat anything else. But
Mhm.
it has to be a comprehensive approach. You
Yep.
can't treat airway at the expense of teeth falling out.
Right. Right. That makes sense. And that's interesting that you were a sleep technician before. That I wonder how rare that is, for that to be before you did your orthodontic residency or whatever. That's interesting. So do you have
Yeah.
patients do a sleep study before and after your treatment, or do you kind of keep it solely on this is the width we're getting, this is a skeletal, this is what I'm doing, and the sleep portion of that, leave that to the sleep doctor? How do you incorporate that?
That's an excellent question. So first, the orthodontic diagnosis comes first, and if the patient has an error or maxilla and they do have sleep symptoms, MARPE will be MARPE will be part of my plan, whether they did sleep tests or not. So I'm treating the orthodontic diagnosis primarily, and just because we, even though we talk about airway, we expanding airway and we're affecting airway in a legal arena in court, so to speak. You can't say you treat it for an airway, because it's not a mainstream research proven. It's getting there, but it's not yet. So you have to treat what you've been trained for, which is an orthodontic problem, and then airway is a big part of it. But you can't just, like I just said, can't treat airway at the expense of everything else. Mm-hmm. Right. So that orthodontics diagnosis comes first, sleep diagnosis comes second. I work with the local sleep lab, and sometimes they send patients for the expansion, and sometimes patients come in and they don't need an expansion; they just need a bimoxillary advancement. Mm-hmm. Well, sometimes they don't sleep, completely different reasons. Sometimes a vitamin deficiency, or I'll tell you a very funny story. As a sleep technician, we had a patient who was who came in. He literally was sleepwalking, and he came to our practice, and we set him up in a clinic, in a sleep lab, and he slept like a baby. And he said that was the best sleep he's ever gotten. Mm-hmm. And then he went home and was back in the clinic a couple of weeks later. He said, "I don't know what happened." So we had a home system. So I went to his house. I set him up, put a little camera, and then set the recording. And guess what? His wife had a restless leg syndrome, so she was kicking him all night long, and mm-hmm. kept, she was his sleep apnea.
Yeah, yeah, exactly. Oh my gosh! So then that would wake him up. It's so funny.
Yeah, but he so they've been married for many years, so he's been she's been doing that. He would be literally unconscious. She would kick him. He would turn. She would kick him again. He'd turn again. So she kept him awake, subconscious, just like sleep apnea does. But he would sleep hours at a time, and then he would just wake up, and would never be rested until he went to a sleep lab.
I know, and that is so funny. He's like, "Could I sleep here again?" He needs to sleep in a separate bed. I mean, it is true. Like, yeah. The problems, like bed partners. I mean, it really is. It's interesting how probably people it's a lot worse when you get married. You got your bed partner. I just did an evaluation on Friday, and the patient has insomnia. It takes him about 3 hours to fall asleep. He also has sleep apnea. So we have two different things going on. And he told me he used to grind his teeth, but he doesn't anymore, which is a whole other conversation. But his wife grinds her teeth, so she wears a night guard. And I'm thinking, she's probably potentially grinding her teeth because of you keeping her awake. Because what happens is the second he falls asleep after a few hours, he snores, she elbows him. That dynamic, they are both probably so unwell rested, and
exactly.
So sleep apnea, sleep disorders affect the whole family.
So just think about it this way. This patient comes in and he says, I can't sleep well. I need a palate expander, because I've read online that it's going to improve my sleep and breathing. And you do an expansion, and it does nothing for them, because that's not the problem.
It's not the problem. Exactly. So you have to do the orthodontic diagnosis first, which right. Of course, yeah.
You have to do the whole diagnosis first, and absolutely.
And I get so many patients that have narcolepsy, and I refer them to the sleep doctor, and that gets diagnosed. So there's so many problems that are not airway related. So we can't always focus on skeletal expansion, because that might not be appropriate for all these patients. So
that is correct.
That makes perfect sense. And one thing, you were talking about sleep studies, I did my sleep study before I got my expander, and I did the PEZ sleep study, which is with the pharyngeal esophageal manometry. So that was like the gold standard for diagnosing upper airway resistance syndrome, because a regular in-lab sleep study said my AHI was 0. I just had a lot of spontaneous arousals. So I did the PEZ and my AHI was 21.4 with the PEZ. So every 2 minutes, my brain would arouse due to a breathing event, right? That increased effort to breathe, brain would arouse, but my oxygen never dropped. So then I got the MSc and pretty much didn't do anything else at the time I had my MSc. And before the MSc was removed, so it was still in, so it pushes the tongue down, so your breathing's not going to be as good. I did another PEZ sleep study, and my AHI went from 21.4 to 6, just with that expansion. So that was pretty telltale, and with the PEZ study, which is the most fine-tuned. So that was really interesting. So that was proof for me, and I was able to get off CPAP from the MSc.
Fantastic.
Yeah. So that was great. A question about jaw joints. So is there, by doing that expansion with the Tadborn, does that affect the TMJ at all? I mean, pulling everything wider, so how does it fit correctly?
Well, it needs to be managed properly orthodontically for that. So you get the lower tipping, you get the upper tipping, so you need to plan for some intrusion. You basically, you need to rebuild the whole bite.
Mm-hmm. Okay. And a couple more questions, or just a comment here, that I just had a patient, a 9-year-old who has moderate sleep apnea, and I read the sleep study report, and there is CPAP was a recommendation, myofunctional therapy is a recommendation, which is great because they didn't used to put that on reports, but there was no orthodontic treatment recommendation. And I'm just kind of blown away because this child never had orthodontics, never had an expander. He's crowded, transverse deficient. And I just find that really crazy that a sleep physician would diagnose sleep apnea and not have orthodontics as a treatment.
They're just not aware.
Wow.
Yeah. For most physicians, anything above the neck does not exist, right?
Right. Yeah, it just blows my mind, because that is the cure, right? We need to,
Yes.
sleep disordered breathing is an anatomical problem in most cases, especially in a child. We got to grow the jaws forward. I mean, yeah, maybe CPAP temporarily might be important for a certain individual, or when we're talking about a child, but wow, I was just really shocked. So I'm glad this parent found me, because I was able to guide, to the right people to help fix this, to help this child. Okay, so Dr. Ting wanted me to ask you a couple questions. One, what do you see as the future of orthodontics?
Future of orthodontics there will be huge practices where people will still do their conventional drill, fill, and bill, line up the social six and get them out of the door. It will be huge, corporate practices, DSOs, whatever, that, and then it'll be little guys like me and Richard. that will be we for what I like to think of ourselves as we trying to be not just tooth jockeys, but actually do some sort of becomes more of a healthcare profession rather than just tooth aligning.
Yeah. Mm-hmm. Yeah, and
so I think there will be very few in the middle. So most people who really want to take it to the next level will get education in joints, airway, and treat the entire head and neck. And some guys just will still line up the social six, which for some people will be quite acceptable as well.
Mm-hmm, mm-hmm. Yep. I have a question from Dr. Ting, but let me say one other thing. This is what I saw in the Facebook post. Maybe I can throw in here. Somebody said about palatal expanders. Dr. Lipkin says that slow expansion only moves teeth, whereas fast expansion is a skeletal expansion. And they put some
examples. For the conventional expander.
And then
the conventional expander in a child.
Okay, so a conventional expander in a child. So can you explain that?
Yeah, so sometimes people have a term like a slow expansion, or essentially they use either conventional palate expander or removable expansion devices, and that so because the force generated is not enough to split the maxillary suture. maybe just to some very, very limited degree. So they're basically remodeling the alveolar support for the teeth. They're expanding the dental arch. They're not expanding the maxilla.
Right, agreed. And they put some examples of appliances, but some people would call those like growth guidance appliances, and it's more like a tipping of the teeth versus
Yes,
expanding the bone. Okay.
that is correct. A lot of appliances like the DNA, ALF, and all that. And I have a couple of very negative words about those appliances, but they're all tooth moving appliances essentially, and they don't do what people claim they do. And because I've retreated and I get them in my practice so often, people who use those appliances, and then now the teeth are sticking out of the ears, literally.
Yeah. And that was
And then
those were the examples. They said Vivos, DNA, ALF. So is there a place for any of those quote unquote growth guidance appliances or
if
not?
you want to move teeth, that's what you use.
Okay.
I mean, you could. There's nothing you cannot accomplish with Invisalign or braces that you can accomplish with Vivos or DNA or ALF. It's a tooth moving appliance.
They're not
Just
expanding
very,
the
very
bone.
simple. I mean, and then if anyone wants to contradict me on that, give me a proof. Anytime I spoke to any of those, DNA, ALF, or growth guided, modified growth devices, they've never been able to show me the proof, like on a cone beam, that they've changed skeletal structure. Not a single time.
Mm-hmm. Good.
So yeah, teeth might look they might even look good in the beginning, but long term they're not in the bone very often, or tipped, or occlusion is horrible. And a couple of years later down the road, they'll have all sorts of other problems.
Yeah, that's good information. And I remember Dr. Stanley Liu had said about when you're expanding at the midline palatal suture, the bone is growing back. You're growing bone, right? At that expansion, the bone. So think about what happens when you grow bone. He said you're growing now the nasal floor, mucosa, nitric oxide production, like the nose is going to function better. And that was a really good visual for me too, to also think about that versus, oh, we're
Yep.
keeping teeth outwards. Okay. So the last question from this one's from Dr. Ting that says, how can a patient get the best out of the orthodontist, and how can a patient find a good orthodontist?
Reputation, and talk to the peers.
Mhm.
Essentially, just many good orthodontists take multiple courses. They never stop learning.
Mhm.
If you think you know it all, then you're done.
Yeah.
um, it never. I've been doing this for 20 some years, and I still find something that I've either overlooked, didn't know. Sometimes things surprise me.
Mhm.
So I don't think I'll ever know it all, and then I keep learning just like everyone else. And I think a trait of a good orthodontist, they need to focus on uh, the whole skeletal system as a whole. Joints, aesthetics, occlusion, function, airway. It has to be a list of goals that the orthodontist should set to achieve. And if there's sometimes we're able to achieve all the goals. Sometimes some of them have to be compromised on. But if the patient comes to an orthodontist, they pick up an X-ray and the treatment plan is braces, then run.
There you go. That's great. Yep. Really great. Well, thank you so much for your time, because this was so enlightening. And I think I forgot to say in the beginning, but you did Renata Nami's MARPE treatment, right? From Airway.
Yeah, she was just in the office yesterday. We just started her upper Invisalign.
How great. And she posted pictures before and after, and you could see all the dental and facial changes.
Yeah.
And she just looks like she's glowing. It's so great. So kind of to sum up some things from our conversation, we talked about MARPE, and you've even done MARPE on a 5-year-old up to 63-year-old, but there really isn't an age limit, and your cases are all very successful. When you use a piezo, I don't want to say guaranteed, but almost guaranteed we're getting that split in the success. And the success of a skeletal expander is that midline palatal suture split.
That's right.
Perfect. And you can go from 2 TADs in a little child up to 8 TADs in an adult.
I've seen somebody do 10. I mean,
Wow.
I haven't had a case where I needed 10, but You never know.
That's a mouthful. 10 tabs. Wow. But whatever's needed. And I also learned that when we do the transverse expansion, the upper jaw is displaced slightly forward. And it's small amount, but there is a little bit of forward displacement. And my brain just goes to think the Puiseu's law of aerodynamics, or any slight change in the tube, any slight growth is to the power of 4. So we might say it's slight, but that could have potentially a significant impact on someone's breathing.
Sure.
Little things like that. Okay. The piezo for you, in your case, is a male would be like age 25 and a female age 30. When there's a jaw surgery technique, like an MMA surgery, the cuts are going to be different than when we do a MARPE, where the cut is on the midline palatal suture. So it could be beneficial to do a MARPE before a double jaw surgery case. When we do skeletal expander, all these facial sutures are loosening. So we can actually then do a reverse pull face mask in an adult or child, but it's not probably as neat in a child than an adult because you've loosened those sutures and get some AP growth that way.
Yeah, well, in a child, you can get a significant change. In someone who's prepubertal or around the puberty, that you can get a tremendous change. Like
even with just RPE, right? Though even just and
no, specifically with MARPE and a face mask.
Okay.
Like with somebody who's got an underbite, you could advance that upper jaw forward quite a lot.
Great. Okay. And when we're kind of lining up the upper and lower jaws in a upper maxillary skeletal expander technique, you can upright the teeth in the bone using like Invisalign, or a surgically facilitated orthodontic technique like the 𝐃𝐈𝐒𝐂𝐋𝐀 or the PAOO will involve corticotomy on the lower jaw that some patients might need for a little
Ron Iad just he's also happens to be one of my patients currently. So he just did that orthodontic procedure on one of his quadrants.
On upper.
So on the upper. So he just posted a video of the whole process.
That is so funny because I just saw that. I didn't watch the video, but I just saw it said that he just had like a surgical technique. I was like, now what did he do?
Yeah.
Okay, I didn't know that he saw you. Okay, so I got to watch that video. So he does jaw hacks. So I did an interview with him. I know you've done a few interviews with him. So this will be interesting to see how he did the SFOT, because I think he had asymmetry, right? Is that why?
Yeah, so he had not with me, but he had MSC. I think he had every appliance in the book.
He started with the AGA, I believe. Yeah. Mm-hmm.
Yeah. So he's done a lot of stuff, and then finally he had an MSC. I don't know where, but at some point ended up in my office last year. So we started him on a path to get his upper teeth, but he's got some skeletal asymmetry post-extension where one side I could not fix without doing something like SFOT. So that's why he went and had it done. So this way we could move these teeth a little bit further out in comparison to everything else.
So is that common to get skeletal asymmetry with MSC or MARPE, or if the provider's good, that won't happen? I shouldn't say.
Let's put it this way: it really should not happen.
It should not.
And I'm sure you probably heard me say that on one of the Ron's videos. And a lot of times people post skeletal asymmetry expansion cases, and I think it's either misdiagnosis or incorrectly installed device.
Okay. Can you correct an asymmetry using MARPE?
Sometimes.
Okay. That's great. Okay, I was doing my sum up, and now I'm like, oh, more questions. Okay, what's great about this? You have had so my brain goes so many ways because it's so fascinating. You've had 100% success rate using the Piezo and MARPE over the last 2 years. All your patients, the suture has split.
Every single one.
Amazing, wonderful. And your office is in New Jersey, right?
Yep.
Right. That sounds so great. Well, I really appreciate all this information, you taking the time in the middle of your day to educate the audience. We have maybe patients that might listen, but also a lot of providers, professionals, myofunctional therapists, dentists, orthodontists, dental hygienists, everybody. So we really learn a lot from you. So I appreciate your time.
My pleasure.
Thank you so much.
My pleasure. It's great talking to you.
Thank you. Take care. Bye.